sir.
Is this sharing or something?
Yes, we need to share the question so that we can start. Thank you. Dr. Akiwumi, your question is 311 to 320, right?
Yes, 311 to 320.
Okay, thank you. Chief Sawa, thank you so much for always coming to our rescue. His question is 311 to 320. Thank you, sir. We appreciate you.
Okay, good evening, our senior colleagues and other chiefs in the house. My name is Dr. Akinwumi Uju, and I'll be taking questions 311 to 320 of the Braunwald. So starting from question 311, a 66-year-old man with a history of type 2 DM. I don't know if I'm audible. Am I audible?
Yes, please. Please continue.
All right, thank you. A 66-year-old man with history of type 2 DM, gastroesophageal reflux disease, and bilateral carpal tunnel syndrome, present for evaluation of worsening exertional dyspnea. On examination, BP is 108/70, and his heart rate is 80 beats per minute and irregular. The jugular venous pressure is elevated at 16 cm of water. The lungs are clear to auscultation and diminished breath sounds at the bases. S1 is normal. S2 is physiologically split. There is no murmur or gallop. The liver is palpable 2-finger breadth below the right costal margin. And there is mild pitting edema of the ankles. The ECG revealed atrial fibrillation with low limb QRH voltage. And the echocardiogram shows concentric thickening of the left ventricle, 15 millimeters, with a left ventricular ejection fraction of 48% and biatrial enlargement. Mapping of the global longitudinal strain shows an apical sparing pattern, and a 99 technetium pyrophosphate scan demonstrate increased myocardial uptake compared with the contralateral lung. TTR genotyping identifies no sequence variant. Serum creatinine is 1.5 milligram per DL. So the question is, which of the following medications will be most appropriate for treatment of this condition? So looking at the question, so let's just try to analyze the clinical scenario. So we see, can we move up a little bit, please? Sorry, please, can we move this screen up small? All right, thank you. So major thing in the history is that of 60-year-old man, type 2 DM, GERD, carpal tunnel syndrome, presenting with symptoms of heart failure, as evidenced by the dyspnea. The BP is there, 108/70, the pulse is there, irregular. GBP is elevated, lungs are clear, heart sound, S1, S2 is split, no murmur or gallop. So we see a constellation of multi-organ involvement here, type 2 DM, GERD, carpal tunnel syndrome, and with the heart also involved in this. So the catch in the question is the ECG that shows atrial fibrillation and a low limb voltage, QRH voltage. So by the time we see a patient having and echocardiogram that show concentric thickening, we expect that the voltage on the ECG should be high. So we can see the discrepancy between the thickening on echo and also the low voltage. So when we have that, so it's already showing us that this is not hypertension. This is something that the thickness is due to something inside the ventricle that is not really muscle. So when we start thinking about a infiltrative cardiomyopathy here, this kind of scenario, the EF is also given there. Now, the mapping of the global longitudinal strain shows an apical sparing pattern. These echo features are actually in keeping with cardiac amyloidosis. So that's all we can see there. And we know that in cardiac amyloidosis, there are two different types. We have the AL and the TTR, the transthyretin type. So the further thing they give on this question is that the pyrophosphate scan demonstrate an increased myocardial uptake compared with the contralateral. So this shows that the type of the cardiac amyloidosis is the transthyretin pattern with this information. And also the TTR that identifying no sequence variant shows that because under the transthyretin pattern too, there are two different types. We have the heritable or the variant type and the white type. So it's the white type that give this kind of pattern, TTR genotype and no sequence. So it's a white type of the transthyretin cardiac amyloidosis. So the only drug that has been found to be beneficial, especially in cardiac amyloidosis of the transthyretin type, and we have a study that back up the use of that drug. And the study is the amyloid transthyretin amyloidosis cardiomyopathy trial, ATTR-ACT trial, shows that tafamidis actually lowers all-cause mortality and also reduce cardiovascular hospitalization in patients with TTR cardiac amyloidosis. So tafamidis is the right answer there. It's a TTR stabilizer that been found to be beneficial in this type of cardiac amyloidosis. The mavacaptan given the option is not using amyloid, it's using hypertrophic cardiomyopathy. While the patisiran and indocetian option B and C is they are TTR silencer that are used in the polyneuropathy for polyneuropathy in cardiac amyloidosis with or without cardiomyopathy. So patisiran and indocetian are used for the polyneuropathy manifestation with or without cardiac involvement, whereas the tafamidis is the drug that is used in the transthyretin type of cardiac amyloidosis, and it has a study that back up the use of that drug. So that make our answer in that questions to be option D. I don't know if you have any contribution to that or questions. Am I still audible?
Yeah, you are.
Hello? Okay, thank you very much. Is there any contribution or question, or can we move forward?
Okay, can you hear me?
Yes, I can hear you.
Okay, in addition to the study you are quoting, it's also a class 1A recommended indication. Look at the guidelines on both heart failure and cardiomyopathies in the ESC guidelines, most recent one. So it's a type 1, the class 1A recommendation to use tafamidis in TTR amyloidosis. Thank you.
Thank you very much. Thank you. Is there any other further comments, or can we move forward to the next question?
Please, let's continue. Thank you.
Thank you. So question 312. Okay, question 312. 80-year-old woman with history of hypertension and type 2 DM is hospitalized because of progressive exertional dyspnea and autopnea. Examination is notable for an elevated jugular venous pressure. Please, continuation, please. Thank you. 312. 312.
To the angle of the jaw.
Okay, can you hear me? I
Yes,
need
I
to
can
know
hear
that
you.
you're following. Okay, this is where the question ends. Her examination is notable for elevated JVP. Then it continues here to the angle of the jaw.
Okay. Yes, thank you. Yes, to the angle of the jaw. Thank you. Thank you. Yes, pitting peripheral edema with warm extremities, normal blood pressure, and clear mental status. The admission chest radiograph is shown up, figure 3.1, demonstrating cardiomegaly, small bilateral pleural effusion, and vascular engorgement. So those are the findings in the X-ray. So we can just continue. Thank you. Then after 4 days of treatment with loop diuretics, yes, we have the findings already of the X-ray in the question, so we can continue. Thank you. After 4 days of treatment with loop diuretics, she appeared clinically euvolemic with a GVP of 7 centimeters of water. However, the serum creatinine value has risen from 1.6 milligram per dl at the time of admission to 2.3 milligram per dl. Which of the following statement about this patient's condition is not correct? So the question is asking for the option that is not correct. So it's a case of heart failure with complications, with the attending complications, and the complication we can see here is a rise in the serum creatinine, a form of acute injury. So what we're seeing here is it's a cardiorenal syndrome. Cardiorenal syndrome, which are actually the disorders of the hearts and kidneys, in which the acute or chronic condition of dysfunction of one leads to an acute or chronic dysfunction of the other one. So as just a way of brief reminder, we do that it's categorized into 5 types. Cardinal syndrome type 1, 2, 3, 4, 5. So for the 1 and 2, the easy way to remember is the cardio before renal. So for the 1 is the acute heart failure causing an acute kidney injury. For the 2 is chronic heart failure causing the chronic kidney injury. For 3 is the acute kidney injury causing acute heart failure, while the 4 is chronic kidney injury causing the chronic heart failure, while the 5 is due to systemic causes. So that's just a way of quickly remembering the 5 types of cardinal syndrome. And the mechanism that been proposed for. Am I audible? Can I continue?
Please continue.
All right, thank you. So the mechanisms that have been proposed for the development of cardinal syndrome include 1 is the pressure overload. Pressure overload in the sense that, of course, we know that CKD will cause some form of left ventricular hypertrophy, and this can cause pressure overload, and the heart dysfunction can actually occur as a result of that. Also, volume overload is also involved, in which patient with CKD, due to the renal problem, can have reduced urinary output and thereby having volume overload. So that itself can predispose to heart failure. Then also cardiomyopathy, in the sense that apart from the left ventricular hypertrophy, there's also the effect of uremia causing some form of cardiomyopathy. So those are the mechanisms that have been proposed for the development of cardiorenal syndrome. So looking at the options one after the other. So option A, diabetes and hypertension predisposed to the development of cardiorenal syndrome. This is true. The option is asking for the one that is not correct. So option A is true. That's not our answer. Worsening renal function during hospitalization for acute heart failure is an important predictor of early hospital readmission and mortality. This is a true statement. We know that the development of cardiorenal syndrome actually worsens the prognosis of patients with heart failure. So that's a true statement. Decreased renal venous pressure contributes to the cardiorenal syndrome. This option is false. It's actually increased renal venous pressure that has been said to contribute to the development of cardiorenal syndrome. So let's take the other options before we come back to C. High dose loop diuretics therapy activate neurohormones that would contribute to the cardiorenal syndrome. This also is correct. So it's part of the mechanisms that have been shown to contribute to the development of cardiorenal syndrome. A disproportionate rise in blood urea nitrogen compared with serum creatinine is a sign of renal hyperperfusion. So this is correct. This is what we call the azotemia, when the urea will go up while the creatinine will. So that is one of the pointers that will tell us that this is a form of renal AKI going on. So that's a true option. So the correct option to that question is option C, in which is increased renal venous pressure that have been shown to contribute to the development of cardiorenal syndrome, not decreased renal venous pressure. So it's option C. I don't know if there's any contribution to that, or can we move on? Can we move on? So let's go to question 330. Question 330, please. Thank you very much. Okay, so question 313. So this question is is more of trial study questions. So let's go through it one after the other. Which of the following statements regarding therapy for heart failure with reduced ejection fraction is not correct? So we'll go through the options. So A, angiotensin converting enzyme inhibitors improve survival in heart failure more than the combinations of adrenaline plus isobar dinitrate. So we can see here that this is actually the trial by the VFT trial 2, VFT2 trial that VFT2 trial that compare randomized patient into either angiotensin 2 inhibitor and enalapril, and the other arm were on adrenaline plus isobar dinitrate, and they found out that enalapril has a more favorable effect on 2-year survival than a combination of adrenaline and isobar dinitrate. So that's the summary or the results of the VIVE2 trial. So making this option A to be correct. So we are looking for the option that is not correct. So that's not the option. So option B, digoxin therapy decreases hospitalization and mortality in patients with chronic heart failure. So of course, we know that the digoxin investigation group study that studied work on digoxin shows that digoxin actually reduces hospitalization but has no effect on mortality. So that was due to possibly some arrhythmic episodes that were actually produced by digoxin. So we know that this particular option is false because of the fact that the digoxin trial showed that digoxin has no effect on mortality but reduces hospitalization. So option C, angiotensin 2 receptor blockers provide morbidity and mortality benefits comparable to those of ACE inhibitors in patients with heart failure. So this is actually true, and there are different studies that have looked at different angiotensin blockers and ACE inhibitors and look at their benefits, comparing the two in patients with heart failure. And some of those like two, which actually looked at captopril and losartan, Valiant study, which look at valsartan in acute MI with captopril. So then the other one is the resolved trial, which look at candesartan and enalapril. The resolved is the randomized evaluation of strategy for left ventricular dysfunction. So resolved trial looked at candesartan and enalapril. So those are the example of different study that look like different type of ACE inhibitors and ARBs comparing their effect on morbidity and mortality in patients with heart failure. And they find out that the effect is actually comparable to the other one in morbidity and mortality benefits in heart failure. Spironolactone reduces mortality in patients with class 3 to class 4 heart failure symptoms. This is actually the result of the real study, randomized adactone evaluation study, that shows that spironolactone has 30% benefit in patients with heart failure with reduced ejection fraction. This as opposed to the Ephesus trial that shows that eplerenone have 15% reduction in mortality. So from those explanations, then I think there's option E. There's option E that talked about AGL2 inhibitors. Can we go there? Sorry, am I still audible?
Yes, you have, please.
Yes, please. I know you can scroll to that option. There's an option E in this question.
Yeah, they are there already.
Okay, thank you. All right, so yes, sodium glucose 2-transporter 2 inhibitors reduce heart failure hospitalization similarly in patients with or without diabetes. So this is actually the conclusion of the DAPA-HF trial that talked about the effect of the AGL2 inhibitors as reducing morbidity and mortality in patients with heart failure. And this study actually bring AGL2 inhibitor like dapagliflozin high up in the recommendation as one of the guideline-directed antifailure medications, as they have the class 1 indication for their use in patients with heart failure. Thank you. I don't know if I can move forward to the next question.
If there are no further contribution, yes, you can, sir. Thank you,
Okay.
sir.
Any questions or contributions?
Either of the two. Thank you.
Okay, so question 314. Which of the following statement about cardiac transplantation is not true? So the option is talking about the option that is not true. So the option A, use of immunosuppressant agents, cyclosporine, improves long-term outcomes after cardiac transplantation. This option is actually reading the statement, the way it is put, it looks like it's a true statement, because we know that the advent of cyclosporine actually caused a great success in the cardiac transplant patient, in which the use of cyclosporine have been caused a good turnaround, attributed to success rates of cardiac transplant. But I think what is wrong in this option is the long term, because of course we know that chronic immunosuppressant in cardiac transplant patient will still cause some other complications later, like malignancy, infections, and co. So in the short term, the cyclosporine actually improves outcomes in patients with cardiac transplantation, but because of some other problems, dysglycemia, infections, and some other issues that are associated with the use of cyclosporine, so their effect in the long term might not be so excellent. But looking at the other options here now, the other options are younger patients have better survival rates than older patients after cardiac transplant. That this option is true. The age range that have lesser survivor are very young, that is less than 18 years, and the very, very old, more than 65 years. And all these things are actually put in place when they are doing cardiac transplant list, in which patients are carefully selected, not too very old, not those ones that have a very low life expectancy. So age is one of the things that are considered when we're doing the cardiac transplant list. So this option B is correct. Cardiac transplant patient lack the chronotropic response necessary to support the hemodynamic demand of exercise. This option is correct because the cardiac transplant is denervated heart, so they lack the chronotropic response necessary to support hemodynamic demands of exercise. Is correct. Endomyocardial biopsy is the most reliable current technique to assess allograft rejection. This option is correct, though there are some other newer tests that can be done, but the gold standard is actually endomyocardial biopsy. The risk of death from malignancy rises with time after transplantation, while mortality from infections decline. This is actually correct because infections usually earlier on in the after cardiac transplant, and as once the graft is over a year, the risk of infection or mortality from infection actually reduce, as opposed to malignancy, which actually the risk rises with time after maybe 1 year or 2 years. But for infections, the risk for mortality from infection actually reduces after the first year after cardiac transplant. So looking at these options, option B to E are correct. So the right answer there is that option A. Please, can we move ahead?
Hello.
Right. Thank you very much, sir. Please, why is A? Why is it not correct?
Yes, yeah. Yes, that's because looking at the statement, the way it's there, it's looking like a correct statement, because we know that cyclosporine actually improves outcome. But I think the catch there is a long term. Because of the other issues, other side effects or complications that are actually associated with cyclosporine.
But is it not, you yourself already said that infections are what is most problematic for the patient in the short term. So is it not true that cyclosporine actually improves long-term outcomes? Because infection in the short phase, in the long term, malignancy.
Yes.
Well, I was actually about asking you the same question that was just raised now, that because it looks like a true statement to me. So I'm wondering why we are saying it is not true.
Yes, that was what I was saying, that looking at the option, the way it's there, it's actually looking like a true statement. But the only reason I could deduce for that option being false, I think it's a long time, because of other problems that are there with the cyclosporine that can actually also cause problems in a heart transplant recipient. Like because of course these are immunosuppressants, so, and they also have many other metabolic complications that are shared with them with the use.
Yeah, but you know that immunosuppressants must be used, generally in transplant patients, even if it is renal transplant or cardiac. They are all very important because of graft versus host, rejection. You are trying to cause some level of immunosuppression so that the organ can stay or can take. So I don't really get why. I think the statement looks true. Because eventually all patients who have any transplant will need immunosuppressants. Otherwise, it will be rejected almost abruptly. And I think it's part of the care for them. So that option still looks somehow like Dr. Joy said. Thank you.
Okay. Maybe we should read the answer to this. question so that at least we'll be clearer. I was also about raising that question, but I didn't read this part. So maybe we should read the answer so that we'll get a better understanding.
Okay.
Thank you. Dr. Sawa, sir, please.
I don't know if you can go to the answer to question 314.
Thank you.
Okay, so let me read. I don't know if you can still scroll up. Okay, thank you. So the option they chose is A. So let me read. Long-term outcome after transplantation improves dramatically with the introduction of the calcineurin inhibitor. Please, can we go up small? Thank you. Okay. Okay, cyclosporine are the cornerstone of immunosuppression. The median survival of all cardiac transplant patients is now greater than 10 years, with a median survival of 13 years among those patients who are alive 1 year after transplant. By the first year of transplantation, 90% of surviving patients report no functional limitations. The selection of candidates for transplantation is a complex process that integrates assessment of hemodynamics, comorbidities that might limit post-transplantation survival, and psychosocial factors that may impair compliance. Optimal candidates for heart transplantation are younger patients with advanced heart failure, minimal comorbid illness or end organ damage, a history of adherence to prescribed medical therapy, and a strong family and social network. A transplanted heart is denervated and relies on atypical adaptive mechanisms to meet varying demands for cardiac output. As a result of increased venous return at the onset of exercise, the transplanted heart responds with the intrinsic Frankenstein mechanisms to augment cardiac output. Circulating catecholamines levels rise as exercise ensues, providing a delayed chronotropic response. These mechanisms allow near normal hemodynamics functions at rest, as well as a large majority of long-term survival. Of note, beta blocker may impair the heart rate response and should be used cautiously after heart transplantation. Right ventricular endomyocardial biopsy remains the gold standard for the diagnosis of allograft rejection, though newer approaches, including gene expression profiling and donor-derived cell-free DNA, are increasingly utilized for rejection surveillance in some centers. Biopsy are typically performed under a transjugular vein approach and are carried out on a routine schedule during the post-transplantation period and over the life of the transplant. High-grade rejection may be signaled by the development of clinical heart failure, atrial arrhythmias, low QRH voltage on ECG, or echocardiographic evidence of left ventricular dysfunction. However, definitive diagnosis or identification of early or subtle lower-grade rejection requires histologic examination of the myocardium. Allograft rejection and infections are the most common causes of death early after transplant. the risk of infection diminishes with time as the intensity of immunosuppression therapy is reduced. In contrast, the risk of fatal malignancy increases progressively in the years thereafter. The most common fatal early malignancies are post-transplant, lymphoproliferative disorders, and lung cancer. So from here now, I don't think they seem to answer our query. I don't know if you have.
I think the way I understood it, thank you for the readout, sir. I think the way I understood it is that it's like a double-edged sword from this explanation. Yes. That long-term outcomes was actually improved by the introduction of cyclosporine. So they started by saying that, but they now ended by saying that it's like the same thing that helps them to live long jeopardizes their existence because it is the immunosuppression that ultimately to the malignancies.
Yes.
So I think it's not a straight question actually, but telling us that the same sword that they used to barb their head is the same one that cuts the throat. That's just the way I'm looking at it. Okay, thank
you. Yeah, thank you very much. Okay, so we're going to question 315 now. Question 315. Yes, thank you very much. I don't know if you can just scroll up small. Thank you. That's fine. Question 315. Which of the following statements about diuretics in heart failure is true? Mannitol is an effective diuretic in cardiac surgical patients with decompensated heart failure. So, aldosterone receptor antagonists lessen the tendency of angiotensin-converting enzyme inhibitors to cause hyperkalemia. Loop diuretics often result in hypokalemia and metabolic acidosis. The effectiveness of loop diuretics agents is reduced by non-steroidal anti-inflammatory drugs. So, looking at the options one by one, the option A is false because mannitol is actually contraindicated in patients with decompensated heart failure. So that option is false. So both aldosterone receptor antagonists and this inhibitor can actually cause hyperkalemia. And they are part of the drugs that we actually have to stop in patients that develop hyperkalemia on the ward. So saying that the aldosterone receptor antagonist lessen the tendency of this inhibitor induced hyperkalemia is so false. So both of them can cause hyperkalemia. So that option is false. So loop diuretic often result in hypokalemia. That is true. But because of they can also cause hypochloremia. So that can result in metabolic callosis, not acidosis. So that's the option is false, which is components. So option D, the effectiveness of loop diuretics agent is reduced by non-steroidal anti-inflammatory drugs. This option is correct. Why? Because the NSAIDs actually block the circoordinate pathway, which is actually involved in the production of the prostaglandins. And prostaglandins are important in the
we can't hear you, sir. See my network.
Sorry, my network I was just cut off. I'm back now. Am I audible?
Yes, now we hear you loud and clear.
Okay, but we can't hear you again, Dr. Akiwumi Ojo. Oh, sorry, I can't hear you again.
Sorry, am I audible?
You're back, yes.
Your last statement
Hello?
on the
Hello, sorry, am I audible?
Yes, we can hear you now,
Am
but
I
we may need to read the last option again.
I think his network is very bad. He seems to be having significant delay.
okay? Sorry,
Okay.
his network, sorry. Am I audible now?
Yes, please, sir.
All right, thank you. So I said the option D, the effectiveness of loop diuretics agents is reduced by non-steroidal anti-inflammatory drugs is true because NSAIDs block the cyclooctagonate pathway, which is involved in the production of prostaglandins. So these prostaglandins are actually important in the glomerulus, in the afferent and efferent arteries. So that is the link in the interaction of loop diuretics and anti-inflammatory and NSAIDs. So they reduce the effectiveness of loop diuretics. So that option is correct. So that is the right answer in that question 315. I don't know if there's any further comments or contributions to that question.
Well, thank you, sir. That my contribution is just that one, I think this question came out. I don't think it came this last exam. I don't think it came out in exactly this pattern, but it was there. I think I clearly remember question on diuretic and NSAID use. So we should try to understand the mechanism by which it happens, which you just described, you know, and the associated diuretic resistance. This option is, you have not told us why we should buy option.
Okay. Yes, I say that we know that mannitol is used in surgical patients majorly because of the effect on reducing the intracranial pressure, especially maybe after intracranial maybe after a stroke, hemorrhagic stroke, or even in surgical neurosurgery patient. But by the time a patient has, because we should know that mannitol is a osmotic diuresis, which actually work at the PCT, proximal convoluted tubule. So I actually saw that it actually contraindicated in a patient that has decompensated heart failure. So in this option that is saying that mannitol is an effective diuretic in cardiac surgical patient with decompensated heart failure is false.
But that's really how mannitol works. The proximal. I thought you said something about the proximal convoluted tubule.
Yes, that's the site of action of mannitol.
Okay. Okay. All right.
Yes.
Well, the way I just envisaged it was that because mannitol is what's the word now? It's an osmotic diuretic, yes, and it will draw fluid from the cells, intracellular fluid. It will draw them into the extracellular compartment, including the intravascular compartment. So it's actually almost like giving a patient IV fluid. You know, a patient who has decompensated failure, to me, it's like you are loading the person with fluid, which we know that the failing heart will not contract adequately and will only aggravate it only aggravates the condition. Okay.
Hello, Dr. Ayodeji.
Hello, sorry, am I still audible?
Yes, you are, Dr. Joe.
Sorry, I couldn't hear what Dr. Ajayi, his comments. The network,
Dr.
Ajayi, I'm not sure if he's still on.
So what I was just saying was that
I just continue.
Can you hear me now?
Yes, we can hear you now. So,
Can I go to question 3?
Okay,
let's hear Jerry House. You're saying
I was
something. Thank you.
over what you said you didn't hear. So what I was saying was that I couldn't even remember straight off where the main site of action of mannitol is. But the way I used to remember it is that I know it is a osmotically active entity, and it will draw fluid from the cells, okay, into the extracellular compartment, and therefore, by extension, into the intravascular space. So the effect is tantamount to like you are giving a patient in heart failure large volume of intravenous infusion. You know that the heart is failing and will not be able to cope with such load, and therefore it will worsen the heart failure. So that was what I was just trying to explain. The use of the PCT, thank you for pointing that out.
Thank you very much. I think that's explanation is valid. Thank you very much. Thanks.
Thank you very much, Dr. Ajayi. The presenter actually is on the proximal nephron. It acts on the proximal tubule that mannitol
Okay.
actually acts on. Yeah, just that. Yeah.
Yeah, because there were actually a few questions that also, try to test one's knowledge on the site of action of diuretic. So that's something we should bear in mind.
Dr. Ojo, you have the floor, please. Continue.
All right,
Thank you.
thank you. Okay, question 316. Question 316. Sorry, I have to enlarge it. Okay. 55-year-old woman with type 1 diabetes has non-ischemic. Am I still audible?
Yes,
Yes,
you
you
have.
are.
Yes,
Yeah,
but the
but
screen is not there. I want to open my own so that I can continue.
okay.
I can't see the question again from here.
We all cannot see it. So if you
Okay,
can kind
so let me, I want to look for my own and open.
thank you.
Yes, thank you. Okay, so question 316. Sorry, let me just scroll there.
Well, I can't see the screen yet.
Yes, question 316.
Hello, Dr. Ojo.
I don't see anything yet, though.
We can't see your screen, please.
The screen is yet to become visible at our end, though. Can you hear us, sir?
Dr. Ojo. I think the network has started again.
Yeah, it's obviously a network problem.
Yeah.
If rather than let the network put our effort, my take is that if
Sorry, am I audible?
good. Okay, yeah, you are audible, but I get to see your screen, sir.
Dr.
Am I audible?
Ojo, you are
Yes.
audible, but we can't see your shared screen.
But you think sure.
Wow, the network is really playing with us tonight. Please, is
Yeah,
there any
network.
It's bad. It seems all the operators doing
Dr. Ajayi, your own network self, your voice is very scratchy.
Are you serious? Wow.
Please, who else can
Wow.
help? Yeah.
Wow.
Oh, God.
We're having challenges with that then. This one is okay, great. They're coming online. So,
Yeah. We're on question 316, I think. Yeah.
Yes, I want to go there. Okay. So is my screen still visible?
yes, I can screen, but I don't know about others. They'll have to respond.
Yes, we can
You
see
said?
your screen. We can
Okay,
see
you can
your
see my.
screen. Yes.
All right, thank you. So a 55-year-old woman with type 1 DM has non-ischemic cardiomyopathy with a left ventricular ejection fraction of 32%. She is seen in the outpatient clinic following recent hospitalization for worsening heart failure. During that hospitalization, she underwent diuresis with intravenous furosemide, and losartan was converted to sacubitril valsartan. She is symptomatically improved but remains dyspneic, climbing one flight of stairs. Examination suggests no residual pulmonary or systemic congestion. Her current heart failure regimen includes carvedilol 25 mg twice daily, sacubitril valsartan 97.03 mg twice daily, spironolactone 25 mg daily, and torsemide 40 mg daily. An implanted defibrillator is in place. Her blood pressure is 105/70. The ECG reveals a sinus rhythm at a rate of 68 beats per minute with a normal quiet duration. Laboratory studies are notable for serum sodium 140, potassium 4.6, and creatinine 1.7, putting our eGFR at 45 mils per minute per 1.73 meters squared. Which of the following treatment recommendation is appropriate? So we see a patient that has heart failure with reduced ejection fraction, 55-year-old woman, who has been on guideline-directed antifailure medications, carvedilol, sacubitril valsartan, spironolactone, and also on torsemide. But presently, she doesn't have any features of congestion, and she's still symptomatic. They even went ahead and put a device for this patient. ICD is in place. So, and patient is still symptomatic. So the question is asking us for what was the next recommendation for this patient. So the option here is stop spironolactone. This will not be the right option. Why? Because spironolactone is actually one of the guideline-directed antifailure medications. This patient potassium is normal, so we don't have any indication to stop spironolactone in this patient. So that option here cannot be the answer. So let me check the other options. Your second option had dapagliflozin. Dapagliflozin is actually one of the guideline-directed antifailure medication and has a class 1A recommendation in treatment patient with heart failure with reduced ejection fraction. It's also important to know that, as we said yesterday, that it's also even indicated in heart failure with preserved ejection fraction. But because of this patient being a patient with type 1 diabetes, and we know that SGLT2 inhibitors in type 1 DM can actually precipitate euglycemic ketoacidosis. So because of that, that will not be an excellent option in this patient. So option B is out. Then option C talked about to add the digoxin 0.125 milligram daily. Though the digoxin will be useful for this patient because of the ejection fraction, but this is a patient that has in sinus rhythm. We don't see any evidence of AFA, and so that will not actually do anything about this patient's symptoms, being symptomatic NOHA class 3, despite all the medications and the IC that this patient is on. So the digoxin might not necessarily have any importance there because the fact that this patient is sinus rhythm, though we know that the digoxin also has some positive inotropic effects, but I'm not seeing that as key here, looking at this patient profile. So the other option is to add vericiguat 2.5 milligram daily. I'm actually coming to that option. Then to replace sacubitril valsartan with valsartan 160 milligram. Am I still audible?
Sorry for the interruption. Please continue.
Good evening. Am I still audible? Sorry.
Yes.
Yes, you are. Thank you.
Yeah, thank you. So that option E is also out of it. We cannot replace sacubitril valsartan with valsartan 160 milligram twice daily because sacubitril valsartan is actually recommending this patient because his heart failure with reduced ejection fraction. So after eliminating all the other options, the only options that remain is the addition of the vericiguat 2.5 milligram daily. It's actually the drug that is a guanylate cyclase agonist and have been evaluated by the Victoria trial to be beneficial in patients with heart failure and has a class 2B recommendation, meaning that it can be used in patients with heart failure. So after eliminating all the other options, so is that option of vericiguat 2.5 milligram daily that stand out, and that would be the answer to this question. I don't know if there's any other contribution.
Me, I still don't understand the indication for this.
Well, it just the way I understand the question is just that, okay, this is a patient that have had all the guideline-directed antifailure medication. So in terms of medical treatment, the patient has had all the necessary medical treatment, and the patient has even moved ahead to have an ICD in place. So we haven't talked about device therapy. And so the question is asking us for any other thing that can be done for this patient that's still symptomatic after having all the necessary guideline-directed medical treatment. So, and we have only 5 options to looking at other options. They don't seem to be the most correct option in this kind of case. The changing of sacubitril valsartan to valsartan because of the type 1 DM, the digoxin might not really do much in this patient, and the option of stopping spironolactone will not even come because you don't have any indication to stop spironolactone in this patient. So that's left us with only one option, which is the vericiguat. And as I said, the Victoria study actually said that Brexpert is class 2B recommendation. So in the absence of no other correct option, so that's why we're going for that option.
So in a nutshell, I think the way I'm understanding, when a patient has been on guideline-directed medical therapy, and the patient is still not doing well, the patient is already on adequate doses of the guideline-directed medical therapy, and patient is still not doing well, then for the purposes of reducing morbidity, mortality, hospitalization, then we now come to the CGWAT. Okay. All right. Thank you so much, sir.
Thank you very much.
Has anybody seen this drug before?
I've not seen it too.
That's
I've not seen
it's funny, right?
People are always saying things that's your end. I mean,
I've never seen it, Chief, sir.
okay. At least we don't see
it's only in the book. It's only in the book that we are seeing it.
I tell you, I was initially looking suspiciously that would they talk about it? But we know that because of the narrow therapeutic index, patient is in AF and all that, you know. I know they won't want to. They're always demonizing the digoxin. It's all right.
Okay, so can we move forward to question 317? Yes, I think I'm the one controlling it now. Sorry.
Yes.
So question 317. Yes, so question 317 says each of the following statements about myocardial contraction is true, except okay, so option A, beta adrenergic stimulation increases the concentration of intracellular calcium. Okay, let me move forward to the other options. Beta 1 adrenergic stimulation promotes production of intracellular cyclic guanosine monophosphates. Interaction of calcium and troponin C is essential for myocyte concentration contraction. Option D, myosin molecules are tethered with the Z line by the protein titin. Then E, sarcoplasmic reticulum plays a key role in the release of an uptick of calcium. Okay, so let me start from the option E. Option E. So the question is asking for the one that is not true. So option E is true. We know that sarcoplasmic reticulum is very important. Even we talked about the effect of the ATPs and everything, sodium, then causing important to release more calcium to cause contraction. So that is how option is correct. Molecules are tethered to the Z line by the protein titin is correct. So look at the diagram. The myosin actually didn't touch. They don't touch the Z line. So they are tethered. They are attached to the Z line by titin, the protein titin. So that is correct. So the interaction of calcium with troponin C is essential for myocyte contraction. That's correct. We know that there are three troponin C bind to calcium. Troponin C bind to calcium. So that option is correct. So beta 1 adrenergic stimulation promotes production of intracellular cyclic guanosine monophosphate. The second messenger for beta 1 stimulation is not CGMP. It's actually cyclic adenosine monophosphate, it's CMP. So the cyclic vanosine monophosphate is second messenger for nicotinic receptor and not for beta-adrenergic receptor. So making that be option false. And beta-adrenergic stimulation increases concentration of calcium is correct. So looking at that, the first option there is option B, in which the beta-adrenergic stimulation second messenger is cyclic adenosine monophosphate, cyclic AMP, not adenosine monophosphate. So I don't know if you can move by. Can I move from? Is there any contribution or question?
Please move on.
Can I move forward, please?
Yes, please, sir.
All right, thank you. So question 318, a 45-year-old woman who underwent autotropic cardiac transplantation because of familial dilated cardiomyopathy present 2 months later for routine post-transplant surveillance. An endomyocardial biopsy is obtained. Which of the following statements is not correct? So the first thing is that when we look at the figure, the biopsy there, what we can say is that you can see lymphocytic infiltration, and also the cardiac myocytes there's some disarray in the arrangement of the cardiac myocyte in that picture, and a lot of lymphocytic infiltration. These two are in keeping with allograft rejection. Now, so going back to the question said that this happened 2 months after the transplant, meaning that we know that rejection can be hyperacute, acute, or chronic, in which hyperacute happens minute to hours after the transplant, and is mediated by the pre-existing antibodies to the antigens from the allogenic materials. And so this will not be in keeping with hyperacute rejection, because, as I said, hyperacute rejection happens minute to hours. This patient comes 2 months after the transplant. So talking about the acute rejection, it's actually happened up from the first week up to 6 months after transplant, and is mediated by the T cells, the T cells. So it's a T cell mediated process. So with that explanation, we know that this particular presentation is in keeping with acute rejection. The third type of rejection is the chronic rejection, which occurs, which is also called late graft failure, which is happens many years or a long time after the transplant. So this is an acute rejection from the clinical presentation and the histologic slide that we have there. So let's go through the options. Endomyocardial biopsy is the most reliable technique to assess for this complication. This is correct. We have also said in previous question that endomyocardial biopsy is good standard to diagnose rejection. So that option is correct. This disorder is caused by pre-existing recipient antibodies to allogenic antigens on the vascular endothelium of the donor organ. This option defines hyperacute rejection. And we have said that this case is a case of acute rejection. So that makes this option B to be false. So C, lymphocytic infiltration and myocyte necrosis are the most important biopsy features in the diagnosis of this disorder. This is correct. And that's what we can see in the slide. So then D, most episodes of this complication arise less than 6 months after transplantation. So I said earlier that acute rejection occurs weeks to up to 6 months after the transplant. So this option is correct. So post corticosteroid therapy is the treatment of choice for this finding. So this is false. So this is true. So the only false answer there is the answer option B, and the reason is that that option defines hyperacute rejection and not the acute rejection that this question is talking about. So I don't know if we have more comments or questions on that option. Or can I move forward to the next question? Can I move ahead, please?
Please move ahead.
Please.
Thank you very much. I just have two more questions too. So question 319. Which of the following statement is not correct? Heart rate and ventricular stroke volume. So this option is correct. You know, cardiac output is equals to heart rate and time. The myocardium extract oxygen from blood nearly maximally and 40%. This option is also correct. Exercise. Oxygen consumption can increase up to 18-fold. It said that during exercise, oxygen consumption can actually increase up to 4-fold, but as the demands increase, it can actually increase up to 18-fold. So this option is correct. The peak oxygen consumption and the anaerobic threshold is measured by cardiopulmonary exercise testing and are highly reproducible when measured days or weeks apart. So measurement of cardiopulmonary exercise testing is actually one of the ways to test the cardiac performance, and is one of the tests to do when we want to list a patient for cardiac transplants, we want to do the cardiac performance. So the option D is correct. The measured peak oxygen consumption of 20 mL per minute per kg exercise testing indicates severe functional impairment. It is said that the oxygen consumption should actually be more than 20 mL of less than 20 mL per minute is actually reduced. But for severe functional impairment, it actually should be less than 12 mL per minute per kg. So the right answer for severe is 12 mL per minute per kg, not 20. So that's what makes this option E.
The network. Please, let's be patient. Let's see whether I will come back within the next 1 minute or so. Dr. Ojo, are you back, please?
Yes, I'm coming back. I'm looking for the book. Sorry.
No problem. Thank you.
Yes. Okay, so I have to scroll. Just have one more question. One more question. Sorry, to scroll to the
Dr. Ojo.
Yeah, sorry, it went off again.
Yes, I guess as much. Sorry about that.
No problem, thank you. Sorry, just one question that I have. Sorry. Sorry for the time. Okay, so the answer to question 319 is E, and it's because of that value that was quoted. So severe functional impairment is peak oxygen consumption less than 12 ml per minute per kg at flight testing. I don't know if we have any contribution to that before I go to the last question that I have. Okay, maybe I should just go to question 320. Am I audible?
Yes.
Okay, all right. So question 320, it's somehow not too difficult, it's straightforward. Which of the following statements regarding structural and hemodynamic left ventricular parameters in chronic pressure and volume overload states is correct? So it's talking about option A, left ventricular systolic stress is proportional to intercavitary pressure and chamber radius. This option is Laplace law. We talked about the relationship between this the stress in a hollow chamber and the relationship to the pressure and the radius. So this option is correct because it explains the Laplace law. Looking at the other option, eccentric hypertrophy is characteristic of pressure overload. This is false. We know that eccentric hypertrophy is deal more with volume overload, and is seen in terms like mitral regurgitations, solos valvular regurgitations, and is due to volume overload that actually cause the eccentric hypertrophy. So this option B is false. Concentric hypertrophy is characteristic of volume overload is false. So the interchange is so concentric is for pressure, while eccentric is for volume. So then option D, left ventricular wall thickness is greater in volume overload. This is also false. We know that the wall thickness, which actually
Wow.
Hello, am I still audible?
We hear you loud and clear, although you broke up.
Yes. So that option D is also false, that the wall thickness is more in keeping with pressure overload and not volume overload. So leaving us with the option A as the right answer. So that's my part. I don't know if there's other comment or questions, please.
Sorry. Good evening, everybody in the class. I want to make a suggestion in view of the hitches we're having concerning the projection. Is it possible that everybody can open up his Braunwald, reduce the page of this Zoom, open your Braunwald either in your phone or hard copy or in your laptop, and be reading it, so that the issue of projection will not be taking the whole of our time like this again? Is it possible we get all that, or do we all have copies of this? Just a suggestion, though. Maybe within the week, we will solve the issue of this projection thing.
Sorry, sir, you know it's being recorded. So if
Okay.
there's projection, they won't really, just listening to a voice won't make. So it's
All right.
important there's a projection.
All right.
That's like, yeah.
Thank you. Thank you.
Thank you so much, Dr. Ojo. We'll quickly move on to question, I think that should be 331 to 340. I hope that the network will be friendly with us.
Sorry, should I unshare so that I don't know if someone with good network can share so that I won't keep the house waiting, please.
I think you can. Okay, Sawa, that's okay.
Okay.
Thank you very much.
Okay.
Okay. Good evening, everybody. I'll be taking questions number 331 to 340. Okay. One says, which of the following statements about the joxin toxicity is not correct? Few things I have jotted about the joxin. You know that the joxin has a very short therapeutic window within a serum concentration of 0.5 to 1 nanogram per ml. Now, however, clinical picture of toxicity appears when the serum concentration is greater than 2.0 nanogram per ml. However, the toxicity can actually occur in clinical in a serum concentration far lower than the above mentioned in the conditions of in presence of hypokalemia and hypomagnesemia. This can manifest as visual disturbances, confusion, nausea and vomiting, ventricular and supraventricular tachy and bradycardia. However, the commonest heart manifestation is junctional and ventricular ectopics. It equally presents with bidirectional ventricular tachycardia, atrial fibrillation with slow conduction, etc. Now, in the treatment, we use class 1B antiarrhythmics, that is lidocaine, where the atropine is equally effective here, considering the fact that some of these things can be supraventricular in origin. And vagal stimulation can actually be effective here. DC cardioversion can precipitate ventricular fibrillation in overt digitalis toxicity. And but it is noteworthy to state that the joxin cannot be effectively be removed by dialysis because of its large volume of distribution and its avidity to the binding of plasma proteins. In life-threatening conditions, the joxin can be the antidote is actually a FAB fragment, that is antigen binding section of the anti-immunoglobulin for the joxin. The fragments, and however, it is equally good to note that in rare cases of toxicity, recurrence of toxicity can actually occur in after 24 hours, 24 to 48 hours after administration of this anti-joxin immunotherapy. I think that FAB fragment is what they call digiband. Then we'll go back to the question. They say each one is not correct. Then we have lidocaine is useful agent for treating arrhythmia due to digitalis excess. We've said that true, can be used. Second and third degree atrioventricular blocks in this setting often respond to atropine. That is true. Recurrence of digitalis toxicity may occur in 24 to 48 hours after administration of anti-digoxin immunotherapy. That we've said also before, even though it's rare, but it does occur. Now, direct current cardioversion may precipitate ventricular tachycardias in patients with digitalis intoxication and should be avoided. That is true. Now, the option E says dialysis is effective in the case of massive overdose. We've said that dialysis is not effective considering the wide distribution of digitalis and its ability to avid binding to the plasma proteins. So the correct option here is option E. I don't know if there's more contribution before I move on, please.
Yes. Good evening, everyone. Well, I'll just add one or two more things on digoxin. Thank you, Dr. Uzuke. For digoxin, we should note that it can be an acute toxicity or a chronic one. An acute, maybe in pediatric age group, or maybe people that want to commit suicide, or people that are not sure of the dosage and just took quite a number of tablets. But in chronic toxicity, most times people that are using it maybe based on indication, but most times in chronic heart failure. And at such stages, although they say that the level in the serum should be between 0.6 and 0.1, but even if you measure the serum level of digoxin and it's at that range, it doesn't mean that people that have chronic heart failure cannot still manifest maybe digoxin effects or toxicity. This is because of other things that might come up, maybe elderly age, maybe renal infection or comorbidities that may be there. So for people that have chronic heart failure, they actually manifest the toxicity. They have a low, what would I call it, a low threshold of manifesting the toxicity. So that's why that in people like that, we have to monitor their electrolytes. We have to search for infection in them, and so that we're able to limit the toxicity in such people. Then considering the digiband, as has been said, is highly protein bound, so dialysis is not effective at all in clearing it if there is toxicity. Thank you, Lord.
That's a whole lot. Thank you very much, Adeanju. Any more comments, please? I'll move on.
Sorry, I just remembered another thing. So if there's indication for digoxin, it is cleared in the renal system, but they've said that there is another one, that's digitalis, that it can be used if patients have renal disease and you really need to use a cardiac glycoside. Digitalis is cleared in the liver and not in the renal system. So if for people that have CKD, you can use digitalis in this instead of digoxin. Thank you.
Thank you very much. That's a whole lot. Any more contributions, please? Okay. Question number 332. All right. If the 7-year-old man is admitted to the hospital within 2 hours of severe chest pain, his initial ECG shows 2 millimeter ST segment elevations and small Q waves in leads V1 to V4. Emergency coronary angiography reveals occlusion of the proximal left anterior descending artery without collateral vessel flow. The left circumflex and right coronary arteries are patent without significant obstruction. Primary percutaneous coronary interventions of left anterior descending restores the teeming grade 3 flow. Following coronary intervention is physical examination. Hello. Following coronary intervention is physical examination reveals a blood pressure of 120/70 mm of mercury, a heart rate of 70 beats per minute. Jugular veins are not distended. On lung auscultation, basilar crackles are audible without wheezes. Cardiac examination reveals a normal apical impulse, a prominent fourth heart sound, and a grade 2/6 apical holosystolic murmur. These extremities are warm and peripheral pulses are symmetric and full. The chest radiograph shows a normal cardiac silhouette with interstitial pulmonary edema. Echocardiography reveals a reduced left ventricular ejection fraction of 34% with anterior apical akinesis. There is no apical thrombus. Moderate mitral regurgitation is present. Brief runs of non-sustained ventricular tachycardia are noted on the first hospital day. This current regimen includes aspirin at 1 mg daily, clopidogrel at 5 mg daily, atorvastatin 80 mg daily, metoprolol succinate 550 mg daily, and lisinopril 10 mg daily. Now the question, which of the following interventions prior to discharge would further reduce his mortality risk? I had a brief jotting here. American College of Cardiology and the American Heart Association recommended for ST segment elevation MI pre-discharge prescription to reduce mortality as follows. Antiplatelets, that is aspirin plus P2Y12 receptor antagonists such as clopidogrel. So double antiplatelets here for ST segment elevation MI. A beta blocker, a high-dose HMG-CoA reductase inhibitor, that is statins. 4 is ACE inhibitors, especially when left ventricular dysfunction is present. Now, furthermore, they said for acute myocardial infarction with left ventricular ejection fraction less or equal to 40%, and the clinical heart failure and presence of clinical heart failure or diabetes mellitus. Mineralocorticoid receptor antagonists such as eplerenone should be added based on Ephesus trial, which says that this improves survival by about 15%. Now, the Paradise MI trial did not show any benefit of sacubitril valsartan compared with enalapril in acute myocardial infarction patients. And the implantation of defibrillator prophylactically for a low ejection fraction should be deferred until at least 40 days after an acute MI based on Dynamite trial. Now let's go back to the question. Place an implantable cardiovascular defibrillator that we should only do after 40 days of the event. Yes, after 40 days of the event. 1, exchange lisinopril for sacubitril valsartan. Of course, this has been shown not to be superior to that. Add eplerenone for 25 mg daily. Yeah, that is if there is reduction of ejection fraction less than 40. Add amiodarone, that is for D now. Add amiodarone 200 mg daily. Add add warfarin adjusted to an international normalized ratio 2 to 3. What the textbook requested what the textbook shaded was actually add amiodarone, which is not correct. Because here we have ejection fraction that is less than 40. So rather, we should rather add a Plerenone, 25 milligram daily. That's option C. More comments, please. Thank you. More comments? All right, thank you. In absence of other comments, I think I'll move to the next question. Sarah, could you help us with question number 333, please? Thank you very much, sir. The circulatory support device seen in radiograph in the radiograph in figure 3.3 has been shown to significantly improve survival and quality of life in select patients with advanced heart failure. Common adverse events associated with this therapy include all except which. Okay, the device, can you please show us briefly? Sour. Okay, that is it. Now, that device there in figure 3.3 is actually implanted at heart mate 3, which is a form of modern continuous left ventricular assist device. This is an improvement over the previous model, which is HeartMate 2. And we usually use it as a bridge. Yes, thank you very much. Yes, thank you. We usually use it as a bridge for before cardiac transplant. That is to say, somebody has a irreversible heart failure. We can use this for a patient to hold on until we see a donor to donate a heart for transplant to such a patient. Or we'll use it in as a final therapy for patients who require heart transplants but are not very stable. That's eligible for cardiac transplant. And this particular model has a low thrombosis rate as against MATE2, as I had already stated, as evidenced by Momentum 3 trial. Now, the commonest complication of this device is stroke, which occurs in 10% per year of this device being on. Now, it is equally, the second commonest is actually infection. This could either be in the blood or from a percutaneous drive line. Now, the third is an association with right ventricular heart failure, because this is a continuous flow device that generates increased right-sided venous return and produce interventricular septal shifts that can further impair right ventricular performance. Now, therefore, candidates with pre-operative right ventricular dysfunction are not candidates for this isolated left-sided mechanical support. Now, the fourth in the order is actually GI bleeding, and this is commoner in MATE3 as against MATE2. And this is probably due to the acquired von Willebrand factor defect. That is the breaking down of the von Willebrand polymer to other lesser dimer or other less complex structure of von Willebrand factor. And or it could be due to enhanced development of GI arteriovenous malformation, probably due to the low pulse pressure that is associated with administration of this device. And confounding factor equally includes the profound anticoagulation with antiplatelet therapy in these patients. However, out of these 4 complications named so far, GI bleeding is the least common. So, wow, I can't see the question, see the projected text from my end again. Maybe I should read from my textbook here. I hope everybody has a copy, please. Or can you help us with the projection so that since this is being recorded? Hello? Am I still audible? Wow.
Yes, please, you are.
Okay, thank you.
I guess it's Dr. Sawa's network. Dr. Sawa, you said you've been to the mango tree, sir. The network is behaving.
Yes, mango tree. I don't know what's happening, but I think I will need to climb up. Sorry about that.
No problem, sir. Thank you for helping to share.
Thank you very much, sir. Okay, if we go through the options again, option A says, the question here says accept. Option A says stroke, which is the commonest actually, 10% for every year. Option B says driveline infection, which is true. Option C says pump thrombosis, which is very correct too. Option E says right ventricular failure, which is very correct, and indeed that is why we do not give it for any patient that has right ventricular dysfunction pre-op. And the list of the complications here is option D, which is gastrointestinal bleeding, if we recall our previous charts. But it is noteworthy to state that everything listed here is a complication of this device. But gastrointestinal bleed is the least, and indeed that's what the textbook chose. Contributions, please.
Sorry, can you shed more light on this? What is this drive line? Thank you.
Well, I think the drive line is the line through which the device, that is from which the pocket of the pocket through the device was put into the skin. I don't know if there's any more to it, but please, can help us, sir. Just like where we put the battery for pacemaker or something under the pocket of the skin. I don't know if there's more details to that, sir, or any other person in the house, please.
Chief Kwake, sir.
Chief, sir. Chief, good evening, sir.
Maybe you can help.
Maybe none of them is close by. Perhaps we'll continue on.
Okay.
A common later, we can remember to bring it up.
Yeah, we will note the question down. Thank you, sir.
Thank you very much, sir. Okay, question number 334. 334, please. All right. Okay, thank you very much. A 60-year-old woman with atrial fibrillation and non-ischemic dilated cardiomyopathy is admitted to the hospital with acute decompensation. Acute decompensated heart failure. Her past medical history is notable for type 2 diabetes mellitus, chronic renal insufficiency, and gout. Admission blood pressure is 90/76 milliliter of mercury with an irregular heart rate of 94 beats per minute. And her examination is notable for pulmonary and systemic congestion. Treatment is initiated with continuous IV furosemide infusion at 10 milligrams per hour after an intravenous bolus. However, her urine output remains less than 70 mL per hour, and her serum creatinine increases from 1.4 milligram per DL to 2.1 milligram per DL over the first 48 hours of hospitalization. Short runs of non-sustained ventricular tachycardia are noted on telemetry. Which of the following would be most appropriate in the management of this patient? This patient obviously demonstrated cardiorenal syndrome. That is to say, a renal and cardiac and renal disease. And the risk factors said that are very obvious include the old age, diabetes mellitus, and baseline renal impairment of this patient. Now, current guideline recommends the consideration of hemodynamic assessment in patients who are refractory to initial therapy, as anti-failure therapy in high dose or combination diuretics. Current study shows that ultrafiltration worsens renal function and systemic congestion, and certainly is not superior to pharmacotherapy. Low dose dopamine shows no benefits, and indeed it may worsen ventricular arrhythmias. Nitroprusside cannot be given to this patient owing to the fact that this patient is already hypotensive, and nitroprusside will worsen the hypotension. So, in the view of this, we'll go back to the question again. Addition of dopamine 2 micrograms per kilogram per minute by continuous IV infusion. That is not correct, going by the aforementioned. This may worsen the arrhythmias. Addition of sodium nitroprusside 20 micrograms. Wow. Thank you very much, sir. Addition of sodium nitroprusside 20 micrograms per minute by continuous IV infusion. This will not help us since this patient is hypotensive already. Now, insertion of pulmonary artery catheter for assessment of central hemodynamics. Yes, that is what we really do for this patient, since that is what the current guideline recommends. And initiation of bedside ultrafiltration. That has been shown that not to be superior to pharmacological therapy. I don't know if anybody has more contributions to this or more clarifications. Thank you very much. That's for question 334. Hello, class. I hope I'm audible, please.
Sorry, yes, you are. I'm just wondering, how does, okay, this patient obviously decompensated, deteriorating. We want to treat, she has begun to develop cardiorenal syndrome, and we have succeeded in inserting pulmonary artery catheter. How does that help in managing her condition? Because it doesn't sound like help in managing her condition? Because it doesn't really sound like any therapy. We are doing anything therapeutic. It sounds like we're still trying to make assessment of central hemodynamics.
Yes, sir. I think the guideline states that we should be able to monitor the central hemodynamics while we'll commence further treatment. That's actually what the guideline says. It is the central line, the central catheter monitoring is not necessarily therapeutic, but a closer monitoring process while the treatment goes on, sir.
Okay, so what do we do next now to help this patient? We've inserted the catheter. We are monitoring her hemodynamics centrally. What is the appropriate step to take after that now? Do we now start giving the dopamine? What do we do? Just taking it a step further so that to bring more clarity in this scenario.
Yes. Thank you. If I could still remember something I read earlier on in the week, where it was stated that part of the renal cause of the cardiorenal syndrome is vasoconstriction of glomerular vasoconstrictions, and I think in such setting, something like Vaptan, which helps in the reduction of intraglomerular pressure, those pressures, the vasoactive anti-vasoactive substances released would have been of a help, even though it does not confer improvements in the mortality of this patient, but it reduce a temporary relief of this patient. But the exact next step, really, I didn't really take time to look it up, going by the suddenness of this presentation. Maybe I will look up that and upload it on the class page on or before tomorrow. That's what next step to take. Yes.
Hello.
Hello, ma. Yes, we can hear you.
Yes, I just want to try from residual knowledge. I think that there were some studies that came out in the last between 3 to 5 years in which they were trying to measure the pulmonary artery catheter, the pulmonary hemodynamics, and they came up with some gadgets. I think one of these gadgets is CardioMES and some other sensitive intrapulmonary pressure measurement gadgets that can actually give us the actual hemodynamics and the pressure in the pulmonary system. And this is in a bid to actually manage this patient better. I think that if the pressure is high, I think they go further to add vasodilators, if I remember correctly. They can also go ahead to do mechanical intervention for such group of patients. But that's just what I can recollect. But I know that there are some studies that have come out as concerns this. Thank you. And there's also a comment in the chat box from Dr. He said for initiation of mechanical ventilation. Actually, are you saying that that's the next step?
Well, in absence of provision of a better answer, that remains the truth until we look further and all check further.
Okay, thank you, sir.
Thank you very much, everybody. I don't know if anybody have more contributions. Others, let's move to the next question, please.
Dr. Sawa's network is at it again. Dr. Rukayat, please, do you have a stable network and you can help us to share?
Coming to
Sorry, Dr. Ozuki, I didn't hear that.
I didn't say anything there. It was a distraction, one of the participants.
Okay. Dr. Richard, please can you help us share?
Yeah, today my network has been.
Yeah, this network thing is everywhere tonight. Okay. Thank you.
Let me try. Okay, I'll have it shared.
Yes. It was okay. You can continue. Oh,
I've not seen the shared screen. It is still coming up, man.
okay, sir.
Okay, Dr. Florence sharing has displaced my own.
Sorry about that, Dr. Alagwe.
No problem, no problem.
Yeah. Dr. Florence, please, page 334. I mean, question 334. Wow, this network tonight. Dr. Florence, please, we are only seeing the first page of Braunwald, 12th edition. The slide is not moving.
Please, can she just stop sharing? Maybe Christine will try.
Okay. Dr. Florence, please. Thank you. Dr. Alagwe, please. This network, right? Okay. Thank you very much. Wow.
Dr. Sawa has displaced me again.
Dr. Sawa, just allow a bit. Your network is not stable.
Oh, God.
Okay. So sorry, I
Okay,
didn't
let
know
me
that
share.
question. Go ahead. Go ahead.
Okay, let me try and share, Dr. Sawa.
Go ahead.
Dr. Sawa, welcome back. You need to go on that mango tree, sir, on a lighter note.
On that day. Okay, I need to climb the mango tree.
Yes,
Sorry
sir.
about that.
Thank you. Dr. Alagwe, thank you. Dr. Ozuki, please, you can continue.
I've not seen it on my screen. Sorry. Okay. Thank you very much. Question 335, please.
The network is at it again. Dr. Ozuki, we can't hear you. I can't.
No, I'm not saying anything actually. So I take question 335.
Yes, please.
Figure 3.4 displays posterior, anterior, and lateral chest radiographs of a patient with idiopathic cardiomyopathy, symptomatic heart failure, left ventricular ejection fraction that less than 35%, and left bundle branch block. Which of the following statements about this pictured device is not correct? Yes, I must admit that I had real challenges concerning this device. Why? Because I could not see the picture well, and I wasn't able to get around it really. I tried to make effort to reach out to other senior members of the group, but I couldn't get across to them. I don't know if anybody can be of an assistance. I need an assistance on that question number 335, please.
Dr. Alagwe, please, can you show us figure 3.4? Thank you. Okay, let me just try. It's looking like a pacemaker.
The pacemaker, there is ventricular, there is atrial. But when they said coronary sinus, I couldn't see it.
If you look at the Well, from the, will I call it the roots now, or the battery side, you can see that there are three leads coming out. Do they call it leads or cord now? Coming out from that.
Yeah.
Yes.
And also when you look at picture B, you can actually see the 3 leads. You can see
Yes.
the 2 ventricular leads and the atrial lead.
Yes, you can see one going back.
Yes.
Yes. I think it's that one that goes into the coronary segment.
Okay, one going back, 2 pointing forward, one being ventricular, the other one atrial.
Yes, yes.
Chief Conte, can you help us on this, please?
Yeah, so this is a typical CRT device. Okay, wherein you, hello?
Yes, sir, we can hear you.
Yeah, so it's a typical CRT device, wherein, so the leads that are pointing forward, the one on top is the atrial lead, and the one at the bottom is your usual RV apical lead. And then the one that is going backward is the one that is going into the coronary sinus to stimulate the left side of the heart. So this is a typical resynchronization, CRT device.
Thank you, sir.
Yeah.
Okay, then let's hazard at the options anyway. Then option A says implantation of this device reduces left ventricular dimensions and mitral regurgitation. Of course, this cannot reduce left ventricular dimensions. The implantation only helps is a functional correction, not a structural correction. So option A is unlikely. Placement of this type of device is placement of this type of device is associated with improved survival. I think that should be true. A complication of device implantation is phrenic nerve stimulation with diaphragmatic pacing. I'm not sure of this. Minimization of this form of ventricular pacing is important to prevent progressive heart failure. This looks quite true. QRS duration on the surface ECG is an important predictor of clinical benefits. Not necessarily. I don't know if anybody, and what's the...
You're looking for the answer that is not correct. So everything is correct except one.
Yeah, so I think the obvious one is A. A is the false answer. Yes.
That is
so
not
B,
correct.
Yes, I think it's A. The placement of this type of device associated with improved survival, because that one is clear.
Yes, sir.
In patients who meet the criteria, they have improved survival. Then a complication of the device is phrenic nerve stimulation. So that is a common complication with pacemaker, especially when you put lead at the RV apex. Sometimes, because you screw the lead, especially with the active lead, the lead can go through and touch the diaphragm. So that's why every time you put a pacemaker lead at the apex, you actually test for phrenic nerve stimulation. So you put a hand over the upper part of the abdomen, and then you use 10 millivolt stimulation to see if there is contraction of the diaphragm. So every time you put an apical lead, you have to test for that, because it's a common thing that can happen. And then minimization of this form of ventricular pacing is important to prevent progressive heart failure. Okay, so when like I mentioned, one of the lead is in the RV apex, okay? But now, recently with pacing, to optimize the transmission of impulse within the ventricle and to sort of simulate the natural occurrence, they are advocating more septal pacing, okay? High septal pacing or even bundle branch pacing to make sure that the impulse are following the normal conduction system. That has been shown to give better outcome and prevent the development of pacemaker-induced cardiomyopathy. Because when you put it at the apex, they will end up with a bundle branch block pattern. So even the ones who you do CRT for, they end up showing a right bundle branch, pattern on the ECG. Okay, so doing the high septal or bundle branch pacing combined with the coronary sinus pacing, even for CRT patients, has been shown to give better outcome than the ones where you put the lead in the RV apex. So that RV apex lead is the one that we want to minimize so that it prevents progressive heart failure. So that one is true as well. And then E, the QRS duration on the surface ECG is an important predictor of clinical benefit, definitely. Okay, depend on the width of the QRS complex. Okay, so those who have 150 and above have maximal benefits, class 1 indication. And then between 130 to 150 is actually a class 2A indication to put the CRT device. Yeah, so the wrong answer there is A.
I don't think so. Option A, Dr. Quinte. Option A, those are the when after after doing a CRT, part of the things that showed in the study of those CRT study, I think made it, is that the left ventricular dimension are reduced and the mitral regurgitation reduced drastically. I've forgotten the timing when they achieved that, but A is a true statement.
The mitral regurgitation with resynchronization.
Yes, is a true statement. That's part of the outcome for the studies of
implantation of the device reduce left ventricular dimension and mitral regurgitation.
Exactly. So it's a very true statement.
Okay.
That means that the answer is D. That's minimization of this form of ventricular pacing is important to prevent progressive heart failure. That's D. That's what the textbook says.
Okay, so this A part I've not even really come across it. But usually probably the D1, they're looking at it more to just pacing rather than CRT, because CRT you end up pacing 2 areas of the ventricle. But generally, apical, you want to avoid apical pacing and do either septal or bundle branch pacing to reduce pacemaker-induced cardiomyopathy.
Yes, I agree with that.
Mm.
Can we read the answer so that at least we get their own view?
Yeah, but before we continue, what does this option D, minimization of this form of ventricular pacing?
Sorry?
What does minimization of this form of ventricular pacing, what do they mean by that?
So I was thinking the pacing using the RV apex. When you pace using the RV apex. So probably they are looking at it when you just do pacing without resynchronization. Okay, because the general trend now is to move away from apical RV apical pacing because it is associated with pacemaker-induced cardiomyopathy. Yeah.
So what you're saying is that minimization is a technical term used in
a
CRT that signifies avoiding pacing the cardiac apex. Hello? Hello, am I audible?
Yeah, I did not get what you're saying.
Is it my network? I can hear Dr. Sawed.
Hello, okay, can you hear me now?
Yeah.
When we refer to minimization now in terms of ventricular pacing, is it a standard technical term used to connote the fact that there's no engagement of the cardiac left ventricular apex? Hello?
Yeah.
Oh, we can hear you.
Okay, I will say again. What I want us to understand clearly is this minimization. What does it actually be a technical term in CRT placement? I mean, sorry, in cardiac pacemaker placement? Or it's just literally means minimize in our normal general terms?
Well, sorry, if I might just add something, I don't see that minimization as a special term, as a special cardiology term. I'm just seeing it as an English. That is to say, just supporting what Conte is saying, that we are moving away from this type of pacing to a different type of pacing. Now that is from this apical to septal and coronary sinus, as I said earlier. I think it's just English. I don't think it's a special term, except otherwise. Well, somebody else can correct me if I'm wrong. You know.
I feel, well, maybe I'm understanding the question in a different way. I feel if they have written maximization of this form of ventricular pacing, that is what will be important to prevent progressive heart failure. Because what they are saying is they are pacing both ventricles because they want to achieve synchronization. So to achieve synchronization, you will pace the left, you pace the right. And at the same time, there must be an potential, that's a distance from the right side of the heart, from the atrium too. So, you know, we can have atrioventricular desynchrony, we can have ventricular desynchrony. So to achieve synchronization in TRT, you pace the atrium and both ventricles. So the left ventricle is through the coronary sinus. So if you need to achieve it, you must pace it just the way it is with 3 leads. So I feel if they had put maximization of this form of ventricular pacing, it would have been a true statement. So if they are saying you are minimizing, that would be a false statement. And I quite agree with what Dr. Conte is saying. He's saying the newest, let me say the new techniques now that they use, but that one is not in the setting. That one is to prevent all these erosion, lead, retraction, lead, blah, blah, blah. Lead is from the complications of the lead placement that could happen, that could nullify our synchronization. That's why they talked about, the one is talking about to pace the septal or the LBB so that the attachment to the right ventricle now will be better. The attachment to the apex usually detach. So if you now attach to the septal, the bundle, yes, that's what they do now, so that the pacemaker lead will stay more and it will be able to survive more. So the only thing you just have to do later, if at all, will be even to change battery. You don't have to go and remove leads. That's what I understand by it. Thank you.
Thank you. And I think I've looked at the answer. So what they're explaining, that this statement would have been correct if they were mentioning isolated RV pacing. But because it is resynchronization, that's why that statement is false. So they say, to achieve clinical and hemodynamic benefits of CRT, biventricular pacing must be continuous. Okay? This is in distinction to isolated RV, right ventricular apical pacing, a mode that can contribute to desynchrony and a higher risk of heart failure symptom. Okay? So if it was just isolated right ventricular pacing, then that statement would have been correct. But because it is resynchronization, it does not apply. Yeah.
Thank you very much, everyone. I will have said that we should go to the answer and read it out, but then that's still possible if we want to go there to read it out. Then the question is already noted down. Prof should be taking us pacing soon before the end of the month. I think we should also note this question so that we ask again during the session. Thank you. Dr. Alagbe, should we go to the answer and read it out, please?
I think we have already been able to point the answer out. That is option D, and all the dissenting voices have reconciled their listening about it. If we need further details, I think we should be able to read it. So if there, Andrew, please don't take note of those two questions so far, so that we'll ask Prof later. Yeah, please. I'm not writing now.
All right.
Thank you, dear.
Yeah.
We move on, please. Question 336. Okay. A 68-year-old woman with a history of hypertension, type 2 diabetes, and heart failure with reduced ejection fraction presents with lightheadedness and exertional fatigue. Physical examination shows a jugular venous pressure of 8 cm water, clear lungs, and absence of lower extremity edema. A transthoracic echocardiogram reveals a left ventricular ejection fraction of 40% with global hypokinesis, unchanged from 2 years earlier. Our medications include carvedilol 12.5 mg twice daily, sacubitril valsartan 24 mg, 20 mg twice daily, spironolactone 25 mg daily, empagliflozin 10 mg daily, and furosemide 20 mg daily. Our ECG shows sinus meridian with high-grade atrioventricular block resulting in ventricular rate approximately 38 beats per minute with normal QRS duration, that is 95 milliseconds. Which of the following strategies would be most appropriate to treat her symptomatic bradycardia? Discontinue carvedilol and reassess her rhythm. No, that will not be correct. I'm trying to look at for her heart rate again. Okay, so it shows a high ventricular rate. ECG shows sinus rhythm with high-grade atrioventricular block, high-grade AV block, resulting in a ventricular rate of approximately 38 beats per minute. So if this is the case, I doubt if this is a sinus reading, and that's why they call it a high AV block. So if we discontinue carvedilol, it may not affect anything here, considering the fact that carvedilol acts at the AV node proper. to prolong AV node delay period. Now, B option says single chamber right ventricular permanent pacemaker. Yes, just as had been earlier on said, this single chamber pacemaker will cause pacemaker associated cardiomyopathy in the long run. Now, option C say dual chamber pacemaker. Dual chamber pacemaker. Okay, in this place we can actually say that's not exactly correct, because we can say right atrium and right ventricle or something like that. But it should not still give us that synchrony that we are looking for. So, and option D says cardiac resynchronization. That's biventricular pacemaker. That should be the best thing, because in biventricular, we should be able to resynchronize the ventricles and reduce the chances of pacemaker-associated cardiomyopathy in this patient in the long run. Can you please raise up the option E, please? And thank you very much. And the option E says dual chamber cardioverter defibrillator. Well, our problem here is not that of defibrillation, but that of bradycardia. Thank you very much. I don't know if there's further contributions to this. Otherwise, move on.
Sorry, but with this patient benefit maximum, if you look at that narrow KRS.
Sorry, sir?
The KRS, yeah.
Yes, it says it's very narrow. That means it should be somewhere around the bundle of his, but certainly below the AV node. Hello, sir. More questions, please. Or rather, more contributions, please.
Hello.
Yes, I can hear you.
Yes, I think that this particular question is also related to the previous one. And the reason why D might be the answer is actually because this patient already have both, as the synchrony already, especially he has mechanical synchrony, that's the global hypokinesia, also has structural desynchrony. However, the QRS is still within the QRS is not broad here, is narrow, but patient is still symptomatic despite being on medication. So I think that one fits part of the, then with the IAV degree block, it fits into part of the indication for a CR, biventricular pacing for this patient rather than the other ones. Those are my thoughts. I don't know.
Hello?
Yes.
Hello?
Yes, I can hear you.
Yes. So, based on the guideline, if you just look at the, considering the QRS duration, you would say this patient does not meet criteria for CRT. However, the bottom line is, once a patient has heart failure and then they need a pacemaker, you have to do CRT. Because remember, if you do a right ventricular apical pacing, you're going to give the patient a left bundle branch block. Because anytime you pace the RV apex, when you print the ECG, it comes with a left, not right. It comes with a left bundle branch block pattern. Okay? So even if at the initial assessment, the patient QRS complex is narrow, but once that patient is in heart failure and they need pacing, if you do just an RV pacing, the patient is now going to end up with a left bundle branch block. So to avoid that, once the patient has heart failure and they have indication for pacemaker, whether the QRS is narrow or not, you have to do resynchronization, okay, biventricular pacing. Okay. And then for the E option, the E option would have been true if this patient ejection fraction was less than 35. But since the ejection fraction is above 35, it does not meet criteria for ICD. So if it was less than 35 and it met the criteria for ICD, then you should have done the dual chamber cardioverter defibrillator. So you resynchronize as well as you incorporate a defibrillator if the EF was less than 35.
Okay, so it should now be like CRTD, right?
Yes, yes.
Okay.
Okay, in addition, if you look at the history they gave us, this patient is already having a symptomatic bradycardia. That alone has fulfilled the criteria for a pacemaker, because the heart rate is 38 beats per minute. Patient is already having dizziness, and the fact that there's desynchrony 2 years back, that's now further tells us that patient will need a bit more from a biventricular pacemaker. Thank you.
Thank you, everybody, for your contributions, please. In absence of further questions, I'll take further contributions. I'll take question number 337. True statements about cardiac physical findings in a patient with heart failure include all of the following except, the word is except here. Cardiomegaly is usually absent in primary restrictive cardiomyopathy. Of course, you can't have cardiomegaly when you have the restrictive cardiomegaly. That's primary restrictive cardiomegaly. B, elevated jugular venous pressure and S4 gallop in patients with heart failure are each associated with a poor prognosis. Yes, here this statement is wrong because the correct statement is elevation of jugular venous pressure and an S3, not S4. S3 gallop in the patient with heart failure are each associated with poor prognosis. C, pulsus alternans result from variation of the stroke volume, likely owing to incomplete recovery of contracting myocardial cells. That is correct. D, low-grade fever may occur in advanced heart failure in absence of underlying infection. That too equally is true. They say it may be due to prolong the vasoconstriction and shortening of blood away from the skin. Body is unable to release heat to the environment. Sleep disordered breathing is common in patients with heart failure. Of course, this one is true, but usually towards the terminal stage of the heart failure, who have a chance to kind of breathing. So the correct answer here is option B, elevated jugular venous pressure and S4 gallop. It is not S4 gallop, it is S3 gallop. Thank you very much. More comments, please. In absence of further comments, can we go to question number 338? Thank you very much. 338. Okay, thank you very much. 338. Which of these statements regarding the relationship between effusion pressure and airway pressure in the upright lung is not correct. Okay, at the diagram I drew about that. Yes. Yes, let me take question number 338 again. Which of these statements regarding the relationship between perfusion pressure and airway pressure in the upright lung is correct? Now, just a brief thing I noted down about this is that the lungs is divided into 3 segments. The upper segment, the middle segment, and the lower segment. Now, in the upper segment, the alveolar pressure is greater than both pulmonary artery pressure and pulmonary venous pressure. So it forms a physiological dead space. Now, in the second region, the alveolar pressure is greater than arterial pressure at a certain phase of respiration. Now, in the third segment, which is usually on the basal segment, when we are standing erect, we have that the alveolar pressure is far less than pulmonary artery pressure and pulmonary venous pressure. And this is where the real ventilation takes place. Let's read the options again. Let's now read the options. Option A, pulmonary artery pressure is greater than alveolar pressure at the lung apices. Pulmonary artery pressure is greater than alveolar. No, that's not correct. Because alveolar pressure is greater than pulmonary artery pressure and pulmonary venous pressure at the apex of the lung. That's not correct. Pulmonary venous pressure exceeds alveolar pressure at the lung basis. That's correct, as we had said earlier on. C, measurement of pulmonary capillary wedge pressure is most meaningful in the lung zones in which pulmonary. Please, can you scroll up, please? Thank you. Hello? Okay. Yes, measurement of pulmonary capillary wedge pressure is most meaningful in the lung zones in which pulmonary venous and arterial pressure exceeds alveolar pressure. That is correct. That's the lung basis. And the pulmonary vascular, excuse me.
Hello, Dr. Ozoke.
Yes, this is acting up here. Pulmonary vascular redistribution on the chest radiograph occurs when there is a relative reduction in perfusion of the basis relative to increased apical perfusion. That one is true, as commonly seen in heart failure. So the except answer here, which is not correct, is option A, which is pulmonary artery pressure is greater than alveolar pressure at the lung apex. That is the correct answer now, because that is the only odd one that is wrong in this statement here. 4 contributions, please, and comments before we take the remaining 2. Please, can you scroll up to question number 339, please? Thank you very much. Which of the following is not likely to be a complication of cyclosporine therapy in cardiac transplant patients? Now, we remember that cyclosporine performs its function at the level of T cells. I think it is a T cell helper inhibitor. So gingival hyperplasia is a known side effect. Myelosuppression, it doesn't do anything in the bone marrow, so myelosuppression is odd one out. Hypertension, yes, it causes nephrotoxicity, so hypertension too. It causes tremor, yes, part of the CNS side effect. Fine tremor and seizure, part of the CNS side effect. Hirsutism is correct, and of course we have hepatotoxicity and cholelithiasis. These are part of the complications of cyclosporine, but myelosuppression is certainly not part of it because this acts at the level of the T cells, not at the level of the bone marrow. Thank you very much. I don't know if there's further contributions or comments, otherwise we'll go to the last question. This speed is going up. Okay. Let me take question number 340. Which of the following statements about acute heart failure is not correct? Acute heart failure is not correct. Most patients with acute heart failure present with normal or elevated blood pressure. That is correct. Milrinone has not been shown to improve in-hospital mortality. Yes, but it gives us phosphodiesterase 3 inhibitor that causes vasodilatations. It causes symptomatic relief, but it doesn't have any showing improvement in mortality. Serum vasopressin level are elevated in acute heart failure and contribute to hyponatremia, a marker of poor prognosis. That is true. However, it is both present in acute and chronic heart failure. Now, tolvaptan, a vasopressin receptor antagonist, reduces the risk of death and risk hospitalization for heart failure. Tolvaptan will actually help to reverse the hyponatremia caused by vasopressin, which is a vasopressin receptor antagonist. It helps to prevent its action and reduce the hyponatremia. However, it has not shown any risk, any reduction in death or risk hospitalization in heart failure patients. So it is essentially a symptomatic relief, but it has not shown any benefit in mortality reduction and re-hospitalization. Thank you very much. That's question number 340. I don't know if anyone has contributions or any clarifications for this last question. Thank you very much for your time.
Sorry, it has option E.
Yes, ma'am.
It has
okay,
option E. See, I just scrolled.
Okay. Yes, so okay. Non-invasive ventilation in patients with acute pulmonary edema does not reduce short-term mortality compared with oxygen alone. Sorry, let me take that again. Non-invasive ventilation in patients with acute pulmonary edema does not reduce short-term mortality compared with oxygen alone. And the question here says not correct. Of course, this is true because it has been shown that non-invasive ventilation in patients with acute pulmonary edema reduces short-term mortality. Thank you very much. Hello. Am I still audible?
Yes, you have. Hello.
Thank you.
Please, any contribution or comment? Okay, in the absence of no contribution or further comments, well, I personally think that we should continue. So if we are in agreement, I just continue and take my part. It's 40 minutes to 11. So we need a consensus. Continue. Dr. Ajayi.
Consensus study. Silence means acceptance.
All right then. Okay.
In the worst case scenario, we may not be able to finish. That's the worst that can happen.
Yeah, I'm sleeping though.
Dr. Molade, you can't sleep. Oh. Okay, let me see what I can do till 11 o'clock then.
Yes.
Okay. All right. So.
Yeah, that's better.
Oh, people are talking now. All right. Okay, so I'm taking 341 to 350. So I'll quickly read. Please, contributions and comments are welcome. So the first question, which of the following, 341 rather, which of the following statements about patients with symptomatic failure is not correct? If you remember very well, in heart failure, one part of the things that happen is the neurohormonal activation. And this is in a bid to stop the progression at the initial stage. However, progression of the activation of this neurohormonal pathway is actually what actually consequently leads to a chronic heart failure. And what happens here is that there is stimulation of the neurohormonal system, that's the adrenergic system. And when this happens, the epinephrine is actually stimulated and there is increased release. Apart from that, the low cardiac output also causes activation of the renin-angiotensin system. There's release of aldosterone, and then the result of water reabsorption in such instances. If you also remember that there will be ventricular remodeling, then along the way, there will be stretching of the ventricular wall, and those ones makes the ANP, BNP to actually increase. So also in the case of heart failure, inflammatory cytokines and other inflammatory factors also released, such as TNF, cytokines, interleukins, they're also released during the process of heart failure, and this is towards the end stage. So the progressive stimulation of the neurohormonal system at the end of the day leads to chronic heart failure, end stage heart failure. So I'll go to the options. Option A says plasma norepinephrine level is usually elevated. This is true. Option B says serum B type natriuretic peptide is elevated. Yes, this is true in symptomatic heart failure. Option C says cardiac beta adrenergic receptor density is increased. No, I think the receptor density is actually decreased, is down-regulated. So I think that's a false answer. False. I think that's false. Then option D says serum testosterone level is elevated. Yes, that's true. The renin-angiotensin system is activated, so they'll increase aldosterone, sodium, and water reabsorption, which leads to the cascade of continued chronic heart failure, which is a syndrome. Then the option E says the circulating level of TNF alpha is increased. Yes, I think it's true. Inflammation has been implicated in as a prognostic factor in chronic heart failure, and it signifies the higher the inflammatory cells or cytokines release, it also signifies a poor prognosis. So I think the correct option A is C. Please, questions, comments, and contributions are welcome. Okay, so I move on to 342. 342 says Which of the following statements regarding post-cardiac transplantation complications is not true? Okay, yeah, they're trying to talk about cardiac transplants. After the transplantation, what are the complications that I would say? It has been mentioned earlier that infection in the immediate post-cardiac period, then in the long term, maybe malignancies. So I will just read through the option. Option A says infectious complications are responsible for approximately 20% of deaths during the year after transplantation. That's likely true. During the year after transplantation. Second one says allograft coronary artery disease is the most significant factor limiting long-term survival. Well, I'll come back to that. Option C says the propensity for allograft rejection decreases with time. Yeah, this is possibly true because most times if there is no immediate rejection, the likelihood that there will be rejection later actually decreases with time, especially if the patient is taking the immunosuppressive agent as they're supposed to take it. So I think that will be a true answer. The CMV infection is associated with development of post-transplantation lymphoproliferative disorder. Actually, CMV most times is related to infection. When we have the lymphoproliferative disorder and other malignancies in the post-cardiac transplantation period, is usually due to EBV infection. EBV infection, and the common malignancies that they have are lymphoproliferative disorder. They can also have lung cancer, prostate cancer. I mean, those are the common ones that I came across during the period of my study. So CMV, the lymphoproliferative disorder is caused by EBV infection, post-cardiac transplant, and not CMV. Option E says transplant recipients have an increased incidence of cancer compared with age match control. This is very, very true. They have an increased risk of having cancer when they compare them to their age match control. So I go back to option B, which I left earlier. Allograft coronary artery disease is the most significant factor limiting long-term survival. I think this is true because if you already have an allograft and we have a coronary artery disease at that particular time, this might actually have an effect on the long-term survival of such persons. So the correct option here is D. Post-transplant lymphoproliferative disorder is due to EBV infection and not CMV infection. Thank you very much. Please comment and contributions.
I don't know if you have an idea why post-transplant patients are more exposed to cancer to cancers. Have an idea?
Well, what I came across is actually that number one, because they are using a lot of immunosuppressive agents and other agents. So that's over time has been said to actually increase their risk of having cancer. But I think it deals more with the immunosuppressive agent, the side effects, and then that's what I think, sure. That's what I think. But I don't know if anybody can shed more light on this.
Yeah, that's majorly what it is. When immunosuppressive therapies are being used after transplant, they will reduce, the recipient's ability to control viruses.
Yes.
Most of these are linked or associated with many cancers. So liver cancers, all the Hodgkins, non-Hodgkins, with use of immunosuppressives, those things just come. That correct me.
Okay, thank you very much. I should also mention here that skin cancers are the most common malignancies seen after transplantation. After skin cancer, you see lymphoproliferative disorders and then other malignancies, adenocarcinomas of the prostate, lung, bladder, and kidneys. So the commonest, in case if the question comes in another way, is skin cancer, post-cardiac transplant. Thank you. So question 343, which of the following statements regarding intra-aortic balloon counter pulsation is not correct? Okay, so I'll just talk briefly about IAB balloon. Actually, it's used in patients with cardiogenic shock, maybe post-MI, or basically for cardiogenic shock. And what is done is that a catheter is passed. Maybe they can either use the femoral artery, which is commonly used if there is no contraindication to using that side. I think they also talked about using the subclavian to pass the catheter. And I think the mechanism, they also use the axillary branch of the subclavian at times to pass the catheter of the IAB. And the mechanism here is that is a counter pulsation in which they are trying to ensure that somebody is in shock. So they are trying to actually control the cardiac output that goes out to increase the perfusion and the relaxation, sorry, to help the heart perform its work better, so that the cardiac output that goes out is a little bit commensurate to counteract the effects of the shock. So in the balloon is actually placed about 1 cm distal, just before the tip of the subclavian artery, and it has the function of inflation and deflation. So most times they watch the aortic hemodynamics. So there is a waveform that you actually see when you look at the aortic hemodynamics. There's an arterial waveform which has a notch. Maybe I will send the picture later. So there is a systolic part of the notch and a diastolic part, and that's where they talk about the dichrotic notch. So what is done is that during the closure of the aortic valve, the balloon is inflated. And then during isovolumetric ventricular contraction, the balloon is deflated. But I have to confess here that I've never seen this done before. I only watch videos. So I don't know if there's anybody that have seen it done and can give a better explanation. But I just know that during inflation, I mean, when the aortic valve is closed, you inflate. And then when it's about to open, you deflate. So I think the process of inflation actually allows the heart to have more endostolic, to have more blood. That's it, to increase the endostolic volume. So that by the time you are deflating, the output going to the systemic circulation is higher. That's what I could understand from my study. But I don't know if anybody have a better explanation. But I will go ahead to read the options now. So option A says the tip of the intra-aortic balloon should be positioned just distal to the left subclavian artery. This is very true, and it's just 1 cm. Just 1 cm before the tip of the subclavian artery. Option B says the intra-aortic balloon should be timed to deflate during the isovolumetric phase of left ventricular contraction. This is very true. And at this particular point, the aortic valve is opening. At aortic valve closure, it is inflated. Then C, inflation of the IAB should be timed with aortic valve closure on the arterial pressure waveform. This is very true. Option D says aortic valve stenosis is a strict contraindication to the use of an IAB. Well, the contraindication I came across was aortic insufficiency and also aortic root dilatation and also aortic stenosis. So I think that this will be true. Option A says in the SHOCK 2 trial, IAB therapy did not reduce 30 days mortality compared with medical therapy among patients with acute myocardial infarction complicated by cardiogenic shock for whom early revascularization was planned. So for this, I just checked the SHOCK 2 trial, and this was actually what was there. IAB did not reduce 30-day mortality when compared with medical therapy among patients that have acute MI and in cardiogenic shock. So the correct answer here is option D. Please, contributions and comments are welcome.
Yeah, just to mention a little comment about the inflation and deflation of the intra-aortic balloon pump. So
Yes.
basically, the deflation during isovolumetric contraction is to make sure that your peripheral resistance drops during ejection so that you're able to perfuse the tissues, okay? And then very importantly, the inflation during diastole is very important for myocardial perfusion. Remember, you depend on your diastolic pressure to perfuse the myocardium itself. So once the aortic valve closes and the balloon inflates, it increases your diastolic pressure and then adequately perfuses the myocardium. That is why it is contraindicated to use it when there is severe mitral and aortic regurgitation. Because once the valve does not close, you are not able to maintain a diastolic pressure. Even if you inflate the balloon, everything will just go back into the ventricle and you will not get perfusion of the myocardium.
Thank you so much, Chief Ponte. Very explicit. Thank you. Please, any other comments or contribution? Well, it's 11:03. Should I continue? Okay, silence means yes, right? Dr. Ozuki.
Nobody's saying this. I hope everybody have not slept off.
Dr. Rimolade, are you sleeping? Dr. Alade.
Probably this silence means people are gone already.
I'm awake.
You see now? Okay, so should I just push to 3:45, then we go, or we should just go now? It depends on what we say.
Let's push to 3:45 if others are in support.
Okay.
Chief Alagwe seconded, ma.
Okay, so we push. So 3:44. Okay, it reads thus. A 56-year-old man with OCOM presents because of intermittent palpitations over the past 3 months. The symptoms has improved on metroploxycinate 100 mg daily. A 12-lead ECG demonstrates rate control atrial fibrillation. Its Chartverstus score is 0. What is the most appropriate anticoagulation regimen for thromboembolism prophylaxis? Please, can we go to the option? Okay, so option A says no anticoagulation. Option B says aspirin 325 mg daily. C, clopidogrel 75 mg daily. D, apixaban 5 mg BD. Aspirin, E says aspirin 81 mg daily. Now, we must know that patients with OCOM, they are at risk of atrial fibrillation. So even if you do their Chartverstus score and the score is still 0, it doesn't mean that you cannot anticoagulate them prophylactically. This is because compared to the normal population, they are at increased risk of thromboembolic phenomena. And apart from that, they also have the risk of sudden cardiac death, in which you use an ICD to prevent that. So for this patient, you actually go ahead and anticoagulate, and here a NOAC apixaban 5 mg BD will be the correct answer here. Please, contributions and comments.
Yeah, it's just what you said. I actually read the guideline, was it 2 days ago, for management of OCUM, AHA, ACC. It states that patients with OCUM are persistent or paroxysmal AF, irrespective of their CHADVAS score, should receive a direct acting oral anticoagulant.
Beautiful.
Okay. So it's part of the AHA guideline. So this is one of the conditions that, irrespective of their CHADVAS score, just go ahead and start giving them.
No. Thank you so much, ma'am.
Sorry, did he also specify which?
Yes, it said DWAC, that's direct oral anticoagulant.
Oh.
Okay. Okay, thank you so much. So the last question for tonight, question 345. It says, which of the following statements about the use of adenosine in the management of cardiac arrhythmias is not correct? Option A, adenosine administration aids in the diagnosis of white QRS complex tachycardia. Option B says slow peripheral intravenous administration of 6 to 12 mg of adenosine terminates supraventricular tachycardia involving the AV node. Option C, patients with heart transplant demonstrate an exaggerated response to adenosine. Option D, adenosine may be ineffective in patients who have recently. Option E, flushing, dyspnea, and chest pressure are common side effects of adenosine. Well, adenosine is a common drug that we use, and one of the things that we must know about it is that it has a short half-life, and because it has a short half-life, most times it's given fast, and then you flush after giving the adenosine. And this has been noted to have some side effects, which is what has been listed here. They can have flushing, dyspnea, chest pressure. In fact, some patients can even go into like a mini fainting spell during the period in which you are giving the adenosine. And so it is said that emergency physicians should actually be prepared for that. What adenosine does is to slow the conduction through the AV node, and then it causes a transient AV block at that particular time. So in patient that has accessory pathway, you don't want to give this because it increases the transmission through the accessory pathway, and those can degenerate into ventricular fibrillation or whether sinister arrhythmias. So when you actually block the, when you slow down when there's a transient AV block, this allows you to see other forms of arrhythmia that may not be so obvious before. So you can see other form of SVT, you can see white complex, tachycardia that are not so obvious before. Then I think those, just as it has been written, is 6 to 12 milligram. I think it starts with 6, then you increase to 12. I think if I remember the dose very well, I think that is the dose. But the thing about it is that you don't give it slowly. So if you look at option B, it says slow peripheral intravenous administration of 6 to 12 milligram of adenosine. You don't give it slowly. You give it, it's a drug that you give fast because it has a very short half-life. So for 345, all other options are correct except option B. Yes. I've not explained about the heart transplant, but I think in the heart transplant, they said that there's actually an exaggerated response to adenosine. I think this is because of the this is because they don't do the nervation. They don't do. I stand to be corrected. Maybe because of the preserved denervation, depending on the type of heart transplant that is done. But it says that they have an exaggerated response to adenosine. For option D, adenosine may be ineffective in patients who have recently consumed caffeine. This is very true because the same receptor is used by caffeine, and so when somebody has consumed caffeine and they are already occupying the receptor that adenosine we use, so it is effective in such group of people because there's no receptor for the drug to bind to exert its effects. Thank you very much. It's 11:11 p.m. We welcome contributions, questions, and comments. Thank you very much.
Okay. Please, just to add that option B, if you're giving it peripherally, you will give it slowly. Or if you're giving it into the central vein, you're going to give it fast.
Okay.
Yes,
thank you.
The mechanism of action, I think the duration of action is it 10 minutes or so. So if you're giving it peripherally, you give it fast, flush. But if you're giving it into the central line, you're going to give it slowly.
Slowly. Okay. Okay. Thank you so much for that.
I'm sure that's why they put peripheral there, so that you will know whether it's fast or slow.
Oh, okay. Thank you.
I think it just beyond just giving it very fast. I think the idea, like you said, it have a very short half-life, so you want it to get there and act very fast. So usually you give it IV push. If you have a central line, fantastic. But of course, usually patient is going to come to emergency or patients in the ward and there is no central line, so it's going to be a peripheral line. So what you do usually is to give it IV push and accompany the IV push with 10 ml of normal cellular or sterile water while raising the hand in an upright position so that the adenosine can be delivered rapidly to the site of action. So that's ideal because if you don't do that, the drug is going to get metabolized before you get to the site of action. So usually, of course, you start with Valsalva maneuver. That's the first thing you want to start with. If it's not working, you move further to 6 milligrams, from 6 milligrams to 12 milligrams. You can get to 18 milligrams, and if that is not working, you have the option of beta blocker or verapamil. If that is not working, you can shock the patient or ab initio if the patient has an SVT with hemodynamic instability, you can rather deliver the shock. So the point is short half-life. So you want to quickly give it, flush with 10 ml of sterile water, keep the hand in an upright position so that it can rapidly get to the site of action. Okay.
Yes. Thank you so much, Chief Kweke. Thank you so much. We've missed you though.
Sorry, it's few days have been so hectic for me. Sometimes this part of the world, now they look your face, you have to do the work anyway.
Yeah, we understand. Thank you, sir.
That's yep.
Thank you, Chief Kweke. Thanks a lot.
Thank you.
Thank you,
So
Chief.
the class have said that we should stop at 3:45. It's 11:15 p.m. Right, Chief Alagwe?
If others want to continue, I'm available. But look at the number of the participants. They are dropping.
Yes, yes. And we actually also have stopped at 11 p.m. This is 11:15, and people have had a very hectic day. Although we are still lagging behind. We have barely 5 weeks. So I don't know. We might need to come up with more options on how we will navigate this. We still have like 3 MCQ books to answer, guidelines, curriculum topics. So I don't know.
A lot, right?
So
But
much.
from my experience, what I've understand is that it's not like whatever we're looking at in Braunwald is going to come out in the exam repeated. But the more we enlarge our knowledge base, the more you grow to a level where you can get to the level of examiner or go above the level of examiner. At that time, you're going to pass. So I understand that there's need for us to cover everything, but much more important is further we're picking what we need to know. So of course, I would expect that beyond this 8 o'clock to 11 o'clock, we're still trying to catch up at an individual basis. So the other aspects that we're probably not catching up with right now, I suggest others to do that. But Sunday, we will likely have a discussion on guideline-based management. So I'm trying to work on that. I'll drop the announcement between tomorrow at most. We should discuss guideline on Sunday. So if we can do that, we can bridge the gap. If we can do 2 of them, fantastic. So I'm trying to work on all the logistics. Sorry, I've been out, but I'll speak to 1 or 2 persons, see if that can work. If nobody will show up, I'm available to discuss the topic, at least on Sunday. So that's confirmed. I just have to discuss with the other guys and let them be aware, Prof and the rest, so that it will be a full discussion on that day. So just be rest assured that on Sunday we'll have something by the grace of God. The other thing is just for us to keep with the other area. So we really need to finish Braunwald quickly. This is already about 400. There's a part of Braunwald after now that the questions are mobbed together. So it's not individual questions. So when you get to that part, it's usually faster. But I've gotten almost to 350. It's a sign that we're almost there. So if we can make some extra time to catch up, that is fine. Extra time to catch up, that is very fine. And then I want to encourage everyone go for exam in October to be involved, please. Be strictly involved, because we'll begin to observe that going through Braunwald again when October exam comes around may not be fantastic. So we may rather just go through Braunwald once in a year, and then we can stick to the other parts, recalls, curriculum, some other prof MCQ, and all that, so that we can catch up with every other part of the exam. So, but as long as we discuss it, cardiology, we'll talk about it. I think that's the most important thing. So first of all, because once we do that, we can improve our knowledge base to a level where whatever the examiner is going to raise become easy for you to answer. So that's all from me tonight. Let's see what happens within the next few days. We are going to roll out some other thing to speed up the activity and encourage everyone to be part. At interval, we can do curriculum. Yes.
What about the guideline now for this Sunday?
Yeah, I've just said it. That's very likely on Sunday it will hold. I just have to make the logistics. I need to speak to the moderators. I've not spoken to Prof. I've not spoken to others here. So, but I've just said that I'm trying to work towards 2 persons doing a discussion. 2.
That's
so I'm
from
sure.
Sunday.
Hmm?
Is it the guideline for Sunday?
Yeah, on Sunday.
Who have you spoken to?
I may likely take something on
Yeah.
Sunday. I've not spoken to any other person. So I just said that I'm sure that I will take something on Sunday. But I want to try to make it 2 discussion on Sunday. I've not spoken to any other person, but I've given people topic before, sometime October, August last year.
All those ones will not work now. Maybe the fellow page will just discuss with them, and then maybe I think we may need to. Anyways, after this thing, I'll call you on WhatsApp so that we can talk.
Okay.
All right.
Thank you so much, Chief. Dr. Florence, you have your hand raised.
Okay, good evening, senior colleagues and colleagues. Okay, just a little suggestion, like the previous sets, when they say running out of time, they had to extend their tutorial period from 8 o'clock. They had to start from 7, because I think we are running out of time, and we are not running at a pace that I think is efficient enough. So I think we should sacrifice more time, like starting by 7. I don't know if it is good enough, but I know the previous sets, there was a time they had to start by 7 o'clock. It was initially 8, so they actually had to move it to 7 to meet up with everything. So I don't know, that's just my little suggestion. So maybe we can look into that so we can meet up with other things. Thank you.
Thank you. She's more than good enough if the whole class agrees.
So
It's
if
good.
everybody agrees, a good one. We've done that repeatedly before. So if everybody that are going for exam this year, so this March and October, if you so agree, I am 100% in support. So if you agree, can you just pop respond on the chat?
Anyways, I think let me chip in something, Doctor, quick. Then Dr. Andrew, I think you need to write it on your people, and then you guys will, so that it doesn't look like a Russian decision. For last year October, the 7 p.m. that Dr. Florence was talking about was during the strike period. So it was even 7 to 10, not even 7 to 11, but at least we extended it to 7 to 10:30. But one other thing we did was Saturday was recruited into the whole process, at least 2 hours on Saturday, and then the Sunday guidance. So, but then, since this time is a little bit short,